as the chair of OBGYN at Duke, we just wanted to know what your major responsibilities are, and if you're pretty much clinical, are you doing research and teaching? And I know you just talked to me about some of the members that you also work with, so
Sure.
give us a little bit of background on that.
Sure. Well, we are first of all, Duke University's Department of OBGYN is an academic center. We consider ourselves an academic center of excellence in various areas. We are a top 10 ranked program, as you know, and in GYN in particular, we're ranked, have always been ranked in the top 10 for the last several years in U.S. News and World Report. So we're number 7 this year. We've been number 4 3 or 4 years in a row, and that's primarily because of our innovation in both clinical care and research, I believe. We have my responsibilities as chair is also to be chief of staff for Duke University Hospital, as well as running a very large residency training program with 32 residents. And we have subspecialty fellowship programs in all 4 of the major subspecialties, including infertility, oncology, maternal-fetal medicine, and urogynecology. So we are a full-service department of OBGYN. We feel that we have a very strong clinical program. We have a dynamic education program, which has primarily been my focus over my academic career. And we certainly have a very strong research program in some key areas, including fibroid research. And so that's why you see our title being the Center for Fibroid Research and Treatment, and as well as various other things. My day-to-day responsibilities include patient care because I'm a maternal-fetal medicine specialist, and so I see high-risk pregnant women, as well as deliver patients still. And one of my areas of interest is, of course, women who have fibroids who come into pregnancy and dealing with them, but also women who have fibroids who lose pregnancies. And so that's my reason for getting more interested in fibroids from the GYN perspective, although I have, I don't do actual, myomectomies and treatments. I have enough people to do that, but I do indeed see a lot of those women in follow-up, once they become pregnant and so forth and so on. So that's really the Department of OBGYN. 80% of what I do is administrative, and 20% of what I do is patient care. I also wear a bunch of national hats, as you probably know, with ACOG, as American College of Obstetricians and Gynecologists, as well as our other subspecialty organizations. So that's pretty much me. I have an open door policy, which is the reason I'm so busy, unfortunately, because people are in and out of here all the time, whether it be a resident, whether it be a student, whether it be a faculty member, or whether it be the lady I just met with, which is a midwife, who's just moved to Durham and may be looking for a job. And I was talking to her because she was referred to me by one of my good friends in Philadelphia who has worked with her, and I'd love to hire her.
You are a busy man, Dr. Brown.
Our population is very diverse here at Duke, and we have the community is a large African American community, professional and non-professionals, and we have a rapidly growing immigrant population of Spanish-speaking individuals. And of course, being at Duke, we are also in a center for high education melting pot people from around the world, whether they be from China working on their MBA, or whether they be here doing some kind of unbelievable research and so forth and so on. It's a very stimulating environment to be in.
Wow, it sounds like it. I mean, you listed off so many things that you're doing it's just amazing, and all the different programs that you have, and the Center for Fibroids Research, that is all of the information that our members and our women are interested in hearing about. So thank you so much for that. You talked a little bit about women having fibroids, and losing pregnancies and having high-risk pregnancies because of fibroids. Can you elaborate a little bit on that? Like, how does that, when does a woman know? Does she typically know about her fibroids prior to becoming pregnant, or do they grow with the pregnancy? I've heard
a little bit of both. A little bit of both. In fact, fibroids are so common, number one, as you know, from your reading and so forth. It's the leading cause, has been the leading cause of hysterectomy in this country for a number of years. it's 70 to 80% of women during their lifetime may have one or fibroid or another, and then develop, a symptom from it. So many young women realize that they have a fibroid or may have a fibroid that's asymptomatic even at their first examination. And so it may be a small fibroid, it may not be elaborate, or women will start to develop symptoms where they have abnormal bleeding that wasn't there in their early menstrual life, or they'll start having pelvic girth problems where their uterus will grow and they feel this pressure, and that's when the fibroids are diagnosed. Now, not all fibroids cause problems during pregnancy, but some of them can, because if they distort the cavity of the uterus, they can then interfere with implantation and cause miscarriage. They can also, be in the muscle themselves and just get bigger because they're stimulated by estrogen and not cause any problems at all. Or they can be in a location where they're big enough where they obstruct the passageway where a woman can't have a vaginal delivery. And the other thing that happens with fibroids sometimes is that they will undergo degeneration during pregnancy and outgrow their blood supply and cause pain because it's a smooth muscle like a heart muscle. And that can be the most complicated pregnancies that we deal with women with fibroids. So that doesn't happen that often. But the biggest challenge, of course, is if they're interfering with a woman carrying a pregnancy because of distortion of the cavity, and that's when they have to be removed periodically so that becomes less of an issue. And that's where you get into the myomectomy treatments, which take the fibroid out, leave a scar. And so the other issue is once that woman becomes pregnant, if the fibroids have been removed from the cavity, it acts like having had a cesarean, and many of those women would have to have a cesarean because they really shouldn't labor if the cavity has been invaded and moved. So those are the many, many factors, and we deal with those patients in various ways because we work directly with a lot of the infertility docs and really do a lot of preconceptional as well as post-loss counseling in patients who have those type of problems.
That is interesting. I mean, when I had my myomectomy, that is one of the things that my doctor talked about, and the other physicians that were there, they said, when you do get pregnant, C-section will be the way because of the scarring in the tissue and what have you. So that's really interesting. You made a point about it.
Go ahead. And we actually, and we want patients to be educated about it. Other factor, as you know, is that many professional women are delaying their childbearing. And so and they're discovering that they may have fibroids or other conditions at the time that they're trying to conceive, and that's when a lot of times the fibroids are discovered.
Right.
Even for symptomatic women.
Exactly, and that leads into another point. One of our members said that one of the questions was, should we be looking for fibroids the way we look for breast cancer, the way we do a test every month, so that it's something that can be detected prior to having a complicated pregnancy or realizing that, we can't get pregnant for one reason or another and then realizing that it's fibroids?
I think that the most important thing is for women of reproductive age to get an annual examination, because a good annual examination will usually pick up whether the uterus is normal shape or not normal shape, even in the asymptomatic patient. And then if their uterus feels enlarged or distorted, then an ultrasound is clearly the best method to do that. But since these are really benign tumors, I don't know that it should be any more than the annual examination, and then to be familiar with the fact as to whether they have a family history or not, because these things are so prevalent. They're very likely to be in the daughter or the mother, etc. It's interesting that